Okay, thank you very much for joining me today. I'm going to talk a little bit about biologics for chronic sinusitis, specifically for those with nasal polyps. The who, the when, the why, and which one. I would say there is no hard and fast answer, but certainly we'll go over the data that supports choices of biologics and also choices of different therapeutic options. I'm Bruce Tan. I'm an associate professor at Northwestern University. I'm primarily an otolaryngologist, but also have an appointment in allergy immunology here. These are my disclosures. Overall, things that we'll talk about today are patient-centric focus to understanding both physical symptoms patients with nasal polyps have, also to understand that they don't just have nasal symptoms. There are also other symptoms that we should recognize as potentially being related to their nasal polyps, as well as also the effects it has on the psychosocial aspects of a patient's life. We'll go over some best practice criteria for recommending sinus surgery or biologic therapy, understanding the role of sinus surgery, the role of corticosteroids, and as well as the role of the various biologics available on the market. We're going to differentiate between the new and emerging biologic therapies and also go over some of the data that we've obtained from clinical trials. So overall, chronic sinusitis with nasal polyps, for those of us who regularly see these patients, we know that there's certainly direct symptoms that we attribute to nasal polyps, the nasal symptoms, the nasal blockage, the facial pressure and pain, the smell loss, the nasal discharge. And those are component symptoms for diagnosing chronic sinusitis with nasal polyps. However, it's also important to recognize that there are symptoms that patients that are sort of not directly nasal, but maybe in some ways related to the symptom burden that patients carry. This was a study, a qualitative study where they spoke to 27 patients with nasal polyps. And what they find are there are what they call proximal symptoms, which are symptoms that directly potentially are attributable to some of the nasal symptoms that they have. And these affect patients, particularly in terms of sleep. Nighttime awakenings are quite common amongst patients with nasal polyps. Patients report a lot of fatigue and tiredness as a result of the nasal symptoms. And then there are what we call distal symptoms, which are symptom effects that aren't directly attributed to the immediate symptoms, but also are reported at high prevalence amongst patients with nasal polyps. They affect patients' emotional well-being, social life to some extent. Things like even feeling annoyed can be seen amongst patients with nasal polyps. And then there are also treatment effects depending on what treatments you choose. And there are treatment effects from surgery, treatment effects from corticosteroids, and especially if you're having to use these often, they have a greater burden on the patient experience. Chronic sinusitis with nasal polyps is not just a stuffy nose. It also has an overall significant economic impact. Overall estimate care for patients with nasal polyps in the range of $6 billion. Indirect costs can be measured in terms of missed work. And also when symptoms are inadequately controlled, indirect costs can be estimated at $7,000 per patient per year. And so between the direct and indirect costs is estimated that patients who have nasal polyps, it may cost up to $15,000 per year. We've done some work ourselves looking at patient-reported outcome measures that can measure patient burden. In this study, we interviewed over 150 patients with chronic sinusitis, use their input to try and tell us what symptoms mattered the most, how we can measure them, and to be able to follow them as they get various forms of treatment. And we came up with a 12-item patient questionnaire. 7 of those items directly covered patients' physical symptoms that they have. Many of them, those are those nasal symptoms I mentioned earlier. But some of those also covered things like cough, pressure, sort of mucus in the throat, which are also common in patients with nasal polyps. There were also psychosocial effects that patients told us about and also measured out as having a high burden, which are things like the issue with being kept awake at night because of these awakenings, feeling fatigued, feeling that their condition could get worse, that worry, and the frustration patients have with their nasal condition, with things that we included. It's short, it's concise, and it was developed with extensive input from patients with chronic rhinosinusitis, including about half of the patients had nasal polyps throughout the development and validation of this questionnaire. It is correlated highly with an instrument called the SNOT-22, which you may have heard about. This is another disease-specific quality of life instrument. It should be noted that the SNOT-22 wasn't specifically developed for patients with nasal polyps, was really more meant as a sinonasal test, but is quite widely used, and we do find that the CRS Pro instrument is quite highly correlated with this SNOT-22 instrument, but just in the name, 12 items is certainly shorter than 22 items. When we treat patients with nasal polyps, it's also important to remember that patients with CRS with nasal polyps have common comorbidities, of which asthma is the most common. If you compare patients without nasal polyps in green to those with nasal polyps in blue, you find that the majority of patients with nasal polyps have asthma. But it's not 100%. It should be noted that just because you have nasal polyps doesn't necessarily mean you will have asthma, but certainly it is much more common. Studies that we've done have shown that this asthma, interestingly, is quite frequently onset in adulthood. So these are not always asthmatics that, these patients didn't always have asthma growing up, but they may develop asthma as an adult. Allergic rhinitis, I would say, is also common amongst patients with nasal polyps, with about half the patients with nasal polyps having comorbid allergic rhinitis. There's a variable fraction. I would say 28% as shown here is a bit on the high side, but about 10 to 20% of patients with nasal polyps, depending on your setting, depending on whether you're in the tertiary care setting, may also have this unusual triad of NSAID sensitivity paired with nasal polyps and asthma. But it's always important when you see a patient with nasal polyps to inquire a little bit about whether or not they may be in this group of patients who has AERD. And the reason why that's important is because if you have AERD, or the Europeans will say NERD, not only will you have both the nasal polyps as well as the asthma, but studies suggest that the asthma is also more difficult to manage. They have increased mucus production. There's evidence that patients with AERD have more smooth muscle contractility, increased bronchoconstriction. On the nasal polyp end, patients with AERD tend to have worse sinusitis radiographically. These patients almost always have high eosinophils within the nasal polyps. They also tend to have higher rates of hyposmia and anosmia. The AERD literature previously used to certainly recommend consideration of aspirin desensitization amongst patients who have this form of nasal polyps that has AERD. The aspirin desensitization does seem to result in less ED visits, less medication use, and overall improve asthma symptom scores as well as sinus disease. We traditionally recommend aspirin desensitization for patients with AERD, usually after or around the time of sinus surgery, meaning, usually we don't put them on aspirin before sinus surgery, but shortly after sinus surgery, or maybe as the patient is recovering from sinus surgery, talking to them about initiating aspirin desensitization was generally the pathway. certainly I would say for the AERD patients, whether or not this is still the main recommendation is a little bit under question in the era of biologics, just because biologics can be quite helpful for this patient population, but I'll go over that later on. In order to understand the role of biologics, it's important to understand the pathogenic factors and the molecular drivers of CRS with nasal polyps. And then with that in mind, a lot of the terminology we use about the immunopathology of chronic sinusitis with nasal polyps is type 2 inflammation. Type 2 inflammation, I think of it like an ecosystem. It is not one cytokine, one cell, or one inflammatory mediator or one cause that triggers type 2 inflammation. But many different cell types, many different cytokines do participate in it. But overall, there's some terminology that talks about upstream mediators like TSLP, IL-33. These are things that are secreted by epithelial cells in response to various allergens, irritants, or even pathogens can cause epithelial cells to secrete upstream type 2 cytokines like TSLP and IL-33. There are various immune cells, both of the adaptive immune system, like Th2 cells that likely participate in type 2 inflammation. And there are innate cells, which are things that respond to pre-programmed genetic cues, such as ILC2s or innate lymphoid cells that also participate in type 2 inflammation. Whether it's adaptive or innate, or whether it's even mast cell derived, the key cytokines in type 2 inflammation are IL-4 and 13. The reason why they tend to be mentioned in the same breath is IL-4 and 13 frequently share the same receptor on cells. So whether it's IL-4 or IL-13, the same receptor gets activated. IL-5 is another important type 2 cytokine. IL-5 tends to activate eosinophils, whereas IL-4 and 13 tend to cause macrophages to polarize to M2 macrophages. Epithelial cells get activated in response to IL-4 and 13 and secrete mucus. They themselves undergo some dedifferentiation, causing some epithelial damage. IL-4 and 13 are also thought to cause B cells to class switch and produce IgE, which in turn arms mast cells and basophils. And we think that all of these factors play a role in the end effect, which in our case is, the symptoms of chronic sinusitis, some of the mucus overproduction. We think that these factors play a role in nasal polyp formation, and certainly that inflammation that we see clinically in patients with nasal polyps. When we think of endotypes means things that we cannot see, but classify disease into perhaps treatable ecosystems of inflammation. In chronic sinusitis, we find three major endotypes of disease. There's type 1 inflammation, which is driven by interferon gamma, type 2 inflammation, which I've mentioned earlier, and type 3 inflammation, which tends to be neutrophilic and IL-17 driven. What we find is that things that identify you as having type 2 inflammation are presence of nasal polyps. In our studies, about 80 to 90% of patients in the Western world who have nasal polyps have type 2 inflammation. Things like smell loss are much more common amongst patients with type 2 inflammation. Patients are less likely to have pus on exam when we do our endoscopies. If they have type 2 inflammation, these tend to be more common findings in type 1 and type 3 inflammation. There's a slight male predominance amongst patients with elevated type 2 inflammation in Western countries. So overall, I would say, if you saw polyps, you practice in America, and the patient, is living in the United States, you wouldn't be too far wrong in thinking that this patient likely has elevated type 2 inflammation. There are some of those comorbidities I told you about. Asthma is more common. Allergic rhinitis is more common amongst type 2 patients. If you saw patients without nasal polyps, there is more heterogeneity. Type 1 inflammation is a common inflammatory profile. Interestingly, we find that type 2 inflammation actually is also a common inflammatory profile amongst patients without nasal polyps. But certainly compared to patients with nasal polyps, patients without polyps are less likely to be type 2 than they are if you saw those nasal polyps present. We did a study recently that looked at some of these other predictors you could have that could tell you perhaps some information about the endotype, just because the endotype usually requires you to be able to measure cytokines and all in tissue, which I would say are not clinically widely available at the moment. But your clues, as mentioned, are certainly that smell loss can tip you off that maybe this is a type 2 presentation. Headaches are less common amongst the type 2 patients. Pus, as mentioned, is more indicative perhaps of this type 3 endotype. And so if you saw pus, no polyps, those patients typically don't have type 2 inflammation. So I'm going to switch gears a little bit. Think about a patient. This is a patient, Alex. He's a 41-year-old male patient. He presents with chronic congestion and facial pain. He reports some of the characteristic symptoms: postnasal drip, smell loss, and effects on sleep. He has been on over-the-counter nasal steroid sprays for about 1 year. He has had a prescription for an inhaled corticosteroid, but he uses this only on and off. Has no other atopic history, no history of asthma. But when you look in his nose, you see nasal polyps present. Question is, at this point of diagnosis, what would typically be recommended for treatment next? Okay, so choices are endoscopic sinus surgery. People chose endoscopic sinus surgery or intranasal steroids for regular use. I guess I didn't define some of these. The EDS flu, a short course of oral corticosteroids. And I would say potentially reasonable options. I would say maybe some things I'll go over: this EDS flu and short course of steroids. I think would be how typically I would treat them next, but I'll go over those options. So we get into medical and surgical management options. In the standard of care management, when it's the first time you're meeting someone with nasal polyps, there is certainly some evidence that saline irrigations can be helpful. It should be noted that the studies that show benefit of saline irrigations used high volume irrigation, and they use this hypertonic solution, which is, I know we typically use, if you're just talking about regular neti pot, it's an isotonic solution. It should be noted that there was really no benefit from just a nebulized saline spray, so usually irrigation has to be this high volume irrigation. There are a lot of different intranasal corticosteroids. There's run-of-the-mill nasal steroids, and then there's now these exhaled delivery systems, which is this EDS flu. There's oral corticosteroids. Certainly evidence suggests that they help in the short run. They help quite dramatically in the short run, and they can help with smell loss, but certainly the effects are quite short-lived on average. And then there are antibiotics. The role of antibiotics in nasal polyps is supported by a relatively small clinical trial. I would say, I think it was only about 20 patients in each group. And they showed that there was a small effect of doxycycline in reducing polyp size relative to oral steroids in that study. Doxycycline had a smaller effect, but it was slightly more durable than the effect of the oral corticosteroids. The role of antibiotics has been historically that there's been some association of Staph aureus with CRS with nasal polyps pathogenesis, and that was the reason they chose doxycycline, because of its anti-staphylococcal effects. I would say nowadays for patients who've never had sinus surgery, there is now evidence that this exhaled delivery system, fluticasone, the trade name is Xhance, can be helpful. It was approved in 2017 on the basis of a phase 3 randomized placebo-controlled trial. And what they showed is that compared to placebo, patients on this EDS flu shrunk their polyps by 1.3 points. This was out of 8 points versus 0.6 points on placebo. Polyps were eliminated in about a quarter of patients at 24 weeks compared to only 9% with placebo. And the SNOT-22 score improved about 21 points, which is a moderately big effect. Using their definition for need for sinus surgery was decreased by about 62-67%. So I think certainly for maintenance of the pre-surgical patient, this is a newer option and can certainly be considered prior to endoscopic sinus surgery for patients. Another discussion about oral steroids. Oral steroids also are effective for short-term management of patients with nasal polyps. In terms of adverse events, certainly it should be noted that a lot of the corticosteroid adverse events kick in terms of long-term. I'll go over some of the dose thresholds where long-term steroids effects start to really kick in. We typically use them in shorter courses. I would say as otolaryngologists, we tend to use them in the 2 to 3 week burst kind of time frame. And then there's certain considerations you should always have with oral corticosteroids, especially your diabetics, just because it can affect glycemic control. Patients with glaucoma, especially, one should use corticosteroids very judiciously, just because it can affect intraocular pressure, just even with a short course of treatment. There are cumulative risks of oral corticosteroids. We don't have this literature in the CRS with NP space, but in asthma, where corticosteroids were used quite extensively, there have been studies looking at various effects oral corticosteroids have. And what they find is that there are statistically significant increases in the following things, diabetes, mood changes, cataracts, cardiovascular events are more common amongst those who had oral corticosteroid exposure. But especially for pneumonia and hip fracture, you can see the odds ratios get relatively big in the range of hazard ratios get in the range of 2 to 3. And amongst the patients who received oral corticosteroids as part of their treatment for asthma. It should be recognized also that there's a dose, cumulative dose, where these adverse events become much more pronounced, and that threshold gets crossed at about 1 gram cumulatively of oral corticosteroids. And 1 gram, for the way we use steroids, is crossed relatively easily. I tend to use a 2-week course of oral corticosteroids. I usually start at like 30 milligrams and taper in that second week. But just counting out doses of oral corticosteroids, which I would cross that 1 gram threshold, it comes out to about 3 2-week courses, and you've crossed this cumulative 1 gram threshold that some of these adverse events start to be quite measurable amongst patients receiving these courses of oral corticosteroids. So back to the patients again. Alex is a 41-year-old male patient. We've now, treated this patient with a course of oral corticosteroids and started him on this topical EDS flu. He comes back 60 days after this short course of steroids, but he still has severe opacification and still and then had recurrence of his symptoms of postnasal drip, smell loss, and facial pain. At this point, what would you recommend as next steps for management. So a good number of people are recommending biologics or endoscopic sinus surgery. Since this patient has not had sinus surgery, so in my practice, I usually, discuss endoscopic sinus surgery as a next option. But certainly we'll discuss the relative benefits of it. So certainly sinus surgery is a treatment option for patients with nasal polyps. In sinus surgery, we're removing the polyps in the nasal airway, also removing the inflammatory burden that extends into the sinuses. I do think that sinus surgery, when we talk about sinus surgery, it's not really just sinus surgery, it's really sinus surgery plus post-surgical management with intranasal corticosteroids. And I think that pairing that is important in order to prevent polyp regrowth. Certainly, there are now devices, including steroid-eluting stents that can deliver mometasone for up to 90 days that are become available to patients if they've had prior endoscopic sinus surgery as another method for delivering those corticosteroids. This is a study that we recently published looking at outcomes after endoscopic sinus surgery amongst patients with nasal polyps. In this study, we basically invited patients in 2 to 5 years after surgery just to collect outcomes. If there are otolaryngologists in the room, you know that many times after surgery, patients don't tend to come back and see us just because a lot of times they may be feeling fine. But in this study, we're trying to better get an ascertainment as to how well are patients doing after surgery. And this is, a good time frame after surgery. And what we found was that using this measure of modified Lund-Mackay score, which is a radiographic severity measure, we find that even a median of 3 years after surgery, the radiographic severity was dropped by more than 60%. So it was about a third of what it was when it started. And then patient symptoms as measured by the SNOT-22 were cut by about half about 3 years after surgery. It should be noted that these patients were frequently still on intranasal corticosteroids, usually delivered as rinses or drops, so it's not just sinus surgery alone. But just showing that, after sinus surgery, patients do get durable symptom relief and durable radiographic severity relief after sinus surgery. There's also a recently published randomized clinical trial comparing endoscopic sinus surgery against medical therapy. In this case, medical therapy comprised of use of intranasal corticosteroids as well as oral corticosteroids as needed. This was published by Witske-Valken's group in the Netherlands. And what they did was they randomized patients at baseline to either endoscopic sinus surgery or continued medical therapy. And then they followed patients. Patients were allowed to switch over, so meaning that if they had medical therapy, they were allowed to switch over to the endoscopic sinus surgery group. But it's important to mention that they were analyzed, even if they switched over to the surgery group, they were still analyzed in the medical therapy group using what's called intention to treat analysis. And what they found was that certainly at baseline, patients look roughly similar. At 3 months, if you had endoscopic sinus surgery, you were doing symptomatically better. This is measured by the SNOT-22 score. By about 12 months, they saw roughly similar levels of symptom improvement in the two groups compared to baseline. It should be noted, though, that as mentioned before, the patients who continued medical therapy used more oral corticosteroids, about 600 milligrams versus 300 milligrams in the patients who had endoscopic sinus surgery. You couldn't quite blind patients to their treatment, so patients knew they had sinus surgery or didn't. There was 20% of patients who were initially assigned to the medical therapy that crossed over into the surgical therapy group, but they were still analyzed in that medical therapy group because of this issue of intention to treat analysis. And I would say this, to me, is the biggest flaw, because I would say those patients had a reason to switch over to the endoscopic sinus surgery group, and those patients also saw the benefits of endoscopic sinus surgery. But I think so far it is still the best evidence we have for endoscopic sinus surgery because it's a randomized controlled trial. And also there were no differences noted in the overall quality of life. And also, you can argue what is the appropriate duration of follow-up of these patients. And in this study, they only follow patients up to 12 months. And, in the lifespan of a patient or nasal polyps, for that matter, 1 year may be a relatively short time frame. This is also just another data slide, just looking at what is the effect of different types of steroid delivery. This was a study done by Richard Harvey. He compared mometasone just spray, like a Nasonex, versus mometasone irrigation, where you would add the mometasone to a rinse and rinse with it. And what they found was that if you rinsed with it, which are those lines with orange, patients generally did better in terms of overall symptoms. Nasal blockage in particular tends to be one of the most sensitive measures to different treatment options. And what they found was that on average, patients who used the irrigation saw greater symptom relief, as well as greater nasal blockage relief, as well as nasal drainage relief after endoscopic sinus surgery. So I would say after surgery, we frequently pair that with an enhanced topical steroid delivery mechanism, whether it be rinses, whether it be one of those EDS flu devices. I do think that sinus surgery should be paired with enhanced intranasal corticosteroid delivery after surgery. There have been some break-even analyses where basically they consider the risks of surgery, benefits of surgery, risks of medical therapy, benefits of medical therapy, average success rates in different patient populations, and looked at what threshold of systemic or oral corticosteroids per year are needed in order for the risk of surgery to the risk of medical therapy to exceed the risk of surgery. And what they find is that if you just had nasal polyps alone, because studies suggest that if you just have nasal polyps with no asthma, your prognosis after surgery is pretty good. There's actually a fairly low threshold of oral corticosteroids where the risks of more medical therapy are exceeded over surgical therapy. So meaning that if you had more comorbidities, you can argue you can continue treating with medical therapy. But if you have less comorbidities, you may actually do better operating on those patients sooner rather than continuing their medical management, just because, especially if you're using a lot of oral corticosteroids, those risks of oral corticosteroids start to outweigh the short-term benefits you're getting in terms of symptom relief. Now we're going to get into a little bit about the guidelines, just because now we have biologics. I'll talk about benefits of biologics later on, but at the moment, there are some guidelines that exist to help us choose what therapies for which patients and how does one make that decision. It's important to note that on the American side, we don't have as many guidelines as they do on the European side. But one guideline that has been put out was one called the Multi-Disciplinary Management Algorithm. This algorithm is actually a little bit longer. If you look at the original paper by Johan, this is a cropping of the overall algorithm. It begins, in this case, for that patient like Alex, who has already had oral corticosteroids, has already had that EDS flu device. it says that, at that point, the majority of these patients, if they're surgically naive, should consider endoscopic sinus surgery as their next management option. As mentioned, after endoscopic sinus surgery, it should be paired with post-operative management with steroid irrigation or intranasal corticosteroids. If the symptoms persist or they recur after surgery and these topical steroid delivery, then these patients can be considered for a biologic. They could be considered for revision surgery. They could be considered for aspirin desensitization if these patients have AERD. They could be considered for steroid-eluting implant. You could also consider a short-term corticosteroid response. You should always assess the effects of these treatments as you're going. There is a minority of patients at that point, like Alex, who've already had the course of oral corticosteroids, already had the EDS flu, where maybe they're too sick to consider sinus surgery. Maybe the asthma alone is so poorly controlled or so severe that maybe it's become a contraindication to surgery, or also, you'd be thinking about biologic treatment independent of their sinus disease, where a biologic can be considered. Or there's some patients where they just have a philosophical disagreement with sinus surgery, and they just are not willing to consider it, where a biologic can be considered. And I think this is a fairly reasonable algorithm given all the different options we have available to us. The Europeans have two guidelines, which I'll go over. One is this EPOS guideline, and this one says that biologic treatment should really be only considered if the patient has bilateral polyps who already had endoscopic sinus surgery. And there are three of these criteria required, basically some evidence of type 2 inflammation. If you had nasal polyps and you've had surgery, that tissue, if it was analyzed, may show you evidence that is likely to show you evidence that there's high tissue eosinophilia. There are some studies that say blood eosinophilia can be a surrogate, and so you can look for that. If they need a lot of oral corticosteroids a year, that can be a sign. SNOT22 should be over 40, which generally indicates relatively severe symptom manifestations. As mentioned, that smell loss is a type 2 symptom. And, if they have that, at least three of these criteria, one can consider a biologic, according to this EPOS guideline. One can also look in the United States at how the wording of the FDA indication is worded. You can see that in the United States, these are the three approved indications, FDA-approved biologics for nasal polyps. And you can see that all of these have the word adult. So at the moment, these three biologics are only approved for nasal polyps in adults. There's some subtle differences in their wording. Dupilumab's inadequately controlled nasal polyps. Omalizumab is indicated for nasal polyps in an older patient with inadequate response to nasal corticosteroids. And then mepolizumab is add-on maintenance treatment for adult patients with nasal polyps. Sometimes, some of these little word gymnastics are what insurance companies will choose to deny approval of biologics on. But you can say that I would say they're somewhat, what is inadequately controlled, what is maintenance treatment. Those are somewhat nebulous terms, and so I would say the indications do provide a certain amount of latitude for using these biologics in patients. The third guideline to consider is this Euphoria Guideline, which was also put out by the Europeans. In this guideline, there should be bilateral polyps present. There's also consideration of whether or not the patient has endoscopic sinus surgery. If they have had sinus surgery, you need less of these criteria. If you have no history of sinus surgery, you need more of these criteria. But just recognizing that in the Euphoria guidelines, unlike the EPOS guidelines, the criteria are a little bit, the EPOS guidelines required all patients to have had sinus surgery, whereas the Euphoria guidelines do leave a little bit of wiggle room for starting a biologic on patients who have had no history of sinus surgery. So putting all that together for Alex, who has had that course of oral corticosteroids, has had the course of EDS fluticasone, using that multidisciplinary consensus, you'd say that this patient should be considered most of the time for sinus surgery unless there are contraindications that were not previously uncovered. The Euphoria guidelines, despite this patient being surgically naive because he has asthma and all those symptoms, one actually can consider a biologic. The EPOS guidelines, because he has not had sinus surgery, this patient should be considered for, it cannot be considered for a biologic yet. But nonetheless, with all of this, a lot of shared decision-making has to go on with patients and, helping them choose the next step in treatment. And in order to understand what type of treatment to do and what type of biologics to consider, understanding the data behind biologics is important, and I'll go over that now. So at the moment, there are 3 biologics approved. The first one that was approved was Dupilumab, which I believe had its approval in 2019. The Dupilumab studies considered patients in 2 major groups of patients. One received Dupilumab for about 6 months, and then they came off treatment. And one can see is that the effects on nasal polyp size, these all used a 0 to 8 grading system, and all required a polyp grade of greater than 5 in order to participate. It was 5 or greater. And what you saw is that the patients treated with Dupilumab reduced their polyp size by about 2. But when they came off treatment, there was some return of polyp size, and you can see that the patients who were in the placebo group didn't see any change in polyp size. If they were treated for a full year, the polyp size shrunk slightly more than they did at 6 months. I think this one also there was some difference in the dose of Dupilumab studied twice a month versus once every month, and the patients who received the Dupilumab twice a month did slightly better than the patients receiving it once every month. You can see that the nasal congestion scores also in both these studies were certainly significantly improved compared to placebo. You can see that the symptoms started to come back in that 24-week study where they came off drug at about 6 months. They also looked at it using this hazard model, where just basically they used a surrogate endpoint of need for oral corticosteroids or surgery. And what you see is that if you're in the Dupilumab treated group, there was a lower risk of needing oral corticosteroids or sinus surgery by 52 weeks compared to the placebo group, where about 41% of patients were indicated for either sinus surgery or more oral corticosteroids, showing the overall efficacy of Dupilumab compared to placebo. There have been some analyses done retrospectively, this one by Claire Hopkins, that showed that these are forest plots showing that whether you had no prior surgery or many prior surgeries, the patients who received Dupilumab did better than placebo. This one I thought was interesting. They broke it down also by how long ago it was since the last sinus surgery. And there was statistical significance in all groups, so meaning that whether your last sinus surgery was a long time ago or very recently, Dupilumab still was of use to you. But interestingly, there seems to be potentially a greater effect of Dupilumab if patients were treated fairly soon after sinus surgery. But remember, these patients all had nasal polyps, so it's not like you're treating patients who have no symptoms and no polyps with Dupilumab. These patients had bad, large polyps that had recurred fairly soon after surgery. But it was interesting here that there may be some incremental effect for starting the patient with a bad recurrence earlier on rather than much later on. The second biologic that has been approved for nasal polyps is omalizumab. The study showed that if you were treated with omalizumab in red here, you had about a 1 point polyp reduction versus those that were on placebo. In the study, they had some arms that switched patients on and onto an open label extension, and you can see that the patients who were on placebo, when they went on label, you could see that polyps did shrink. But you can see that off treatment at about 1 year, the patients, whether they were originally assigned to omalizumab or originally assigned to placebo and switched to omalizumab, started to get some regression of nasal polyp size, meaning the polyps got worse. The nasal congestion scores also did somewhat similar things. So both these studies, I would say, suggest that omalizumab and Dupilumab, even if you treated patients for 6 months, maybe a year, there's some regression of symptoms once they come off treatment. And that regression of symptoms does occur relatively rapidly. You can see in terms of symptoms, by about 6 months coming off drug, you've lost about half the effect you had on treatment. But omalizumab is approved for nasal polyps. It did seem to reduce the need for surgery, reduce polyp size, and you can see it in both their studies. It did so more effectively than placebo. Mepolizumab is the third biologic now approved for nasal polyps. In the mepolizumab study, these patients all had to have had prior sinus surgery. The blue bars here are the patients who received drug active treatment. The gray bars are the ones who received placebo. And what you see is the blue bars have a bigger spread. This is of polyp score, so those who had no change or worsening versus those who had improvement. So 1, 2, 3, 4, 5. You can see that the blue bars happen more frequently amongst the mepolizumab treated group. This one is in regards to the obstruction score, and you can see that the 1 to 3 point improvement in the nasal obstruction score was more common amongst those who received mepolizumab, and that was the basis of improvement. It should be noted that the nasal polyp score reduced relatively modestly, only by 0.73 points in mepolizumab relative to placebo. This is that same hazard curve looking at placebo versus mepolizumab, and you would say that in terms of reduction in need for sinus surgery, mepolizumab was able to cut need for revision sinus surgery by about half compared to placebo. There have never been head-to-head trials of these three biologics yet, but there are certainly some retrospective studies of the relative efficacy of each of these three biologics using the data they reported in the clinical trials. This is summarized here and published in this review. And what it suggests is that Dupilumab, for certain things like sense of smell, seems to have a disproportionate effect relative to the other three biologics. But you can see that in terms of quality of life, Dupilumab slightly better, but in terms of reduction in SNOT-22 scores, I would say is not as dramatic as its ability to improve sense of smell. This is in terms of need for surgery or oral corticosteroids, and in this ratio, less is better, and you can see that Dupilumab seems to have a relatively greater effect in ability to reduce sinus surgery, need for further oral corticosteroids, and also has relatively lower treatment-related adverse effects. There's also one study that has directly compared using this sort of published clinical trial data comparing Dupilumab and omalizumab. I stress again, this is not a head-to-head study, but it suggests that Dupilumab seems to be able to reduce polyp score more and reduce nasal congestion score, as well as loss of sense of smell score to a greater extent than omalizumab. The biologics are certainly an evolving space. There are quite a lot of other biologics still in clinical trials, and so there may be more data to talk about in the not too distant future. Benralizumab is still undergoing clinical trials. They did report out some data for one of the arms of the study, and it showed a relatively modest effect, but they are still studying this, and I think the full study will be reported in 2024. There's a study called, there's a drug, and benralizumab targets the IL-5 receptor. There's another study of tezepelumab, and this targets TSLP, which is one of those upstream activators of ILC2s. This is being studied in chronic sinusitis with nasal polyps. They estimate completion in 2024. There's a depemokimab, which is a depot form of an IL-5 inhibitor. So think of it like mepolizumab, but able to be administered only twice a year. And that one is estimated to be completed in another 3 years' time. So certainly a lot of clinical trial activity going on in this space at the moment. And certainly these biologics and their relative efficacy will have hopefully more data to share in the future. So we're going to switch gears to patients again. Samantha, patient who has a previous diagnosis of nasal polyps. She's had sinus surgery only 9 months ago, but she comes back with congestion, sense of fullness, inability to smell, and she does have asthma. She's mostly controlled when she's using her inhaled corticosteroids, but a CT scan still shows a severe opacification of sinuses. Question is, what would people choose? Okay, kind of a lot of different choices here. I think actually, certainly based on those multidisciplinary guidelines, any of these options could certainly be choices. But a lot of times at this point, it's, very much shared decision-making. I think certainly in a patient post-surgery, especially this one's only 9 months ago, it would be important, as long as they're doing the irrigation, they're doing the nasal corticosteroids, thinking about your newer options, just because it is known that certainly surgery is not always curative, and certainly after surgery, there are certainly a known rate of recurrence, 20-35% is not uncommon, even in tertiary care centers. And that patients downstream from sinus surgery may need revision. Sometimes it depends on how long ago that last revision surgery was. There has been some analysis looking at effects of various comorbidities, and certainly with asthma, it seems to, it does seem to reduce the likelihood of success with endoscopic sinus surgery. Certainly asthma and AERD, studies suggest that, median years to polyp recurrence, as well as median years to revision surgery, certainly cut down if you had these comorbidities present. So for these patients, you can also look at guidelines. Patient who has had recurrent polyps despite endoscopic sinus surgery and postoperative treatment. The options are many: biologics, revision sinus surgery, aspirin desensitization, steroid eluting implants, oral corticosteroids are all potentially useful. Euphoria Guidelines, which were the most biologic permissive, would say, biologic should be considered. The EPOS guidelines also say a biologic can be considered. And then in terms of choosing that biologic, choosing what the next treatment choice, discussion of risks and benefits of these choices should be had with the patient. And that's basically what we're talking about in terms of the shared decision making. And in terms of the options available, you can certainly talk about adjusting dose of intranasal corticosteroids. The EDS flu device, I think it can be discussed. I do think the EDS flu device, I do use it for my patients who really hate using nasal rinses or just have some difficulty using rinses. Sometimes I'd say patients with, for whatever reason, large septal perforations struggle to use the corticosteroid delivery systems. And so sometimes this can be an option. Talking about sinus surgery as being able to remove the inflamed tissue. Certainly if a patient has had adequate surgery, then the issue of making holes large enough that steroids can get in isn't there. But sometimes if the surgery previously wasn't adequate, sinus surgery can also be helpful. Not all sinus surgeries are created equal. Certainly biologics, all of them are injections. Patients have to be comfortable with self-administering an injection. And also the downside of biologics is certainly data suggests that frequently they are long-term treatment solutions, just because short-term treatment in studies of 6 months to a year suggests that there's some degree of recurrence. All right, so last few post-test items. Which of the following is a more disease-specific questionnaire for CRS with nasal polyps? Stop 22. SF36 and EQ5D are general quality of life questionnaires. They don't really target the nasal symptoms that you see in CRS with NP. According to the EPOS guidelines, in order to meet criteria for systemic corticosteroids for consideration of biologic treatments, how many courses of oral corticosteroids a year should the patient have had? Yeah, the EPOS guidelines say 2 or more courses per year is the threshold where they say biologics can be considered. Next one, 45-year-old male patient with polyps, currently taking a medium dose inhaled corticosteroid. He has been treated with this EDS flu. He underwent endoscopic sinus surgery, but after sinus surgery, he has had some smell loss and sleep dysfunction. What would be the most appropriate treatment based on the Euphoria guidelines? Euphoria guidelines are relatively biologic permissive, and I would say yes, the Euphoria guidelines would say this patient's indicated for her biologic. In an indirect comparison of available biologics, which therapy has the greatest effect on improving sense of smell, SNOT 22 scores, and need for sinus surgery? indirect analysis would suggest Dupilumab has relative benefits for these endpoints discussed. I know we're at time, but I can stay on for a few minutes for questions. But in summary, I think CRS with nasal polyps has both a direct symptom burden as well as a indirect symptom burden measurable by things like smell, fatigue. There are certainly adverse events noted with oral corticosteroids. And if you're using it frequently or using high doses of it, you should consider alternative options. There's certainly several consensus guidelines looking at surgery versus biologics. I think surgery and biologics are both reasonable options for the patients who failed first-line medical treatment. There may be some advantages of surgery in being able to eliminate nasal polyps durably in some patients, but certainly as biologics are available now, choosing when to do surgery and when to use a biologic is certainly one of the challenges. And at the moment, there have not been head-to-head studies, but sometimes the review of the literature, understanding what is the relative symptomatic objective measure improvement seen with each of the biologics can help you choose the right biologic for individual patients. And with that, I'll take questions. I know people are typing it in. I don't see any at the moment, but if there are any questions, feel free to fire away. All right, so there doesn't seem to be any questions, but all right, if there are no questions, I'd like to thank everybody for attending, and hopefully that helped improve your understanding of the various therapeutic options available for chronic sinusitis with nasal polyps. Thank you.